Okay, so burn management for the non-burn surgeon. This will be a review for most of you. There is a change in the resuscitation formula in the 10th edition ATLS and in the Advanced Burn Life Support course. 2 cc's per percent total body surface area burn per kilogram, as opposed to 2 to 4 cc's. We'll talk about that. Understand initial stabilization, estimate burn size, calculate fluid requirements, and management of smoke inhalation. These are the ABA referral guidelines, basically very permissive. Mayo Clinic's not a burn center. We'll tend to hold on to the smaller burns because it's a lot of local, regional, a lot of Mayo families. But basically any special situation, anything you're not comfortable with, call the burn unit. Okay, so the theoretic zones of a burn, the coagulation is the area of dead tissue from the thermal process. It's dead. You're not going to get that back. There's an injured area called the zone of stasis. If you can maintain perfusion to the zone of stasis, presumably you can allow that to survive, keep a second-degree burn from becoming a third-degree burn, or prevent widening of a burn. And then there's the zone of hyperemia, which this is the inflammatory response, uninjured tissue, but will tend to swell, and this is where a lot of your fluid from fluid resuscitation is going. So the goals of treatment are basically to optimize perfusion to the skin to allow that zone of stasis to survive, and the goal is to prevent fluid overload to maintain euvolemia, which is a problem because everyone knows burns take a lot of fluid. Really, your goal is to give just enough fluid to maintain perfusion, but to minimize edema, which will increase tissue pressure and decrease tissue perfusion. Hypothermia is to be avoided because that leads to shunting of blood away from the skin, yet everyone's impulse is, ooh, burn, put cold saline and gauze on it. And I think that's because whenever we were kids and we touched the hot stove, that's what Mom would do. You'd run it under, you'd run the finger under a faucet. Prevent compartment syndromes. That gets to circumferential deep second and third degree burns. Constricting dressings, which can act as tourniquets as torsos or extremities swell, and then preventing burn wound infection, which is done with wound care, not with IV antibiotics, not with prophylactic antibiotics. Okay, so this is your MOC question. The burn management priorities are the same as ATLS with the exception of stop the burning process first. So if they're on fire,